vessels, and it has nerves. But it's not classified as connective tissue proper per se. Also, it's not calcified, but we're going to see that sometimes calcifications can develop in the PDL space, but the whole tissue doesn't become calcified like bone does. Okay, so that's what we're going to see in the periodontal ligament. Cells, fibrous matrix, ground substance, blood vessels, and nerves, with the main component being the fibrous matrix. You know, it is named a ligament, but it has some features that are different from other ligaments in the body, so it's not classified as connective tissue proper. Okay, let's look at the general organization of the PDL, and then we're going to get into the names of the specific fiber groups, just like we covered the specific fiber groups of the gingiva. If you notice diagrammatically on the small inset you have above, you see these spokes that are oriented in different planes, and they represent groups of fibers called the principal fibers. Okay, so we have areas of dense where these fibers are. I know it only looks like diagrammatically that there's one fiber there, but that spoke just represents groups of fibers. So where these principal fibers are, that represents areas of dense connective tissue. And like the gingival fiber groups, they're type 1 collagen fibers. They're type 1 collagen fibers organized into dense bundles. And what kind of support do fibers provide? Mechanical or biologic? Anybody? Daisy?
Mechanical.
Okay, they provide mechanical support. I reintroduced the attachment apparatus. They help hold the tooth in its bony socket. So they provide these fibers, these principal fiber groups provide mechanical support. Okay, but separating the fiber groups are interstitial areas. And I'm just going to draw a little red where the white space is. I'm just drawing like a blood vessel in cross section. In those white spaces represent what are called the interstitial areas. And they're areas of loose connective tissue, and notice they alternate with the principal fiber bundles. And these interstitial areas contain blood vessels and nerves. And I drew a little blood vessel in 3 of them, of those areas in cross section. So here is where we're going to see biologic support. Remember, biologic support is a function of blood vessels and nerves, and it's true with the periodontal ligament. So what we have is a tissue arranged with alternating areas of dense connective tissue alternating with loose connective tissue so that the mechanical support can be provided and the biologic support at the same time. So this is the general organization. Principal fiber groups alternating with the interstitial areas. if we go to this picture that you have, I just want you to see here. Here are the principal fiber groups. Here's another one. See how they're parallel dense bundles of type 1 collagen here. And then if we notice, they alternate with these areas of loose connective tissue, the interstitial areas. So where the white space is, that's where there's loose connective tissue. And this is just the a blood vessel in that loose connective tissue in cross section. The nerves aren't showing up because they require special stains. So here's another blood vessel. So you see the alternating principal fiber bundles, interstitial area, fiber bundle. So that's the overall organization. And this was just to blow this up, it gets a little blurry. Sorry, I probably shouldn't even put that in there, but you can see the interstitial areas alternating with the dense bundles. Okay, so we've got a strong tissue that provides mechanical support, but it also provides biologic support to surrounding tissues that we'll get into later. So let's focus on this main component, the fibrous matrix, or these principal fibers of the periodontal ligament. And we're going to, so there are 5 groups of principal fibers. There's one group called the alveolar crest fibers, another called the horizontal fibers, oblique, apical, and with multi-rooted tooth, there is a 5th group called the interradicular. And their names make sense as we label them. It's based either on their orientation or their specific location in the periodontal ligament. Okay, and another term I just want you to write in, your book has this term there. They're more commonly known as just the principal fibers of the PDL, but they may be referred to as the alveolodental ligament. It's a connection between the tooth and the bone. Alveolo for bone, dental for tooth. So you may see that term and it just is referring to the principal fibers collectively. Okay, so let's go ahead and label some of these fibers. I'm going to have you do a minor adjustment. And again, notice up here in the gingiva, these are the different gingival fibers represented. And if we go to the crest area, all the way down to the apex of the tooth, and follow that periodontal ligament around, we're going to see different fiber groups. And again, this is just a buccal lingual view of the tooth, but I want you to realize that all of these periodontal ligament fibers can be seen from all views: buccal, lingual, mesial, distal. You know, it's 3-dimensionally, it surrounds the tooth. Okay, Melissa, will you go ahead and just read what it says about the alveolar crest fibers in terms of their location of attachment?
Cementum to the alveolar crest in an apical direction.
Okay, so here we have the cementum. So I'm just labeling the first 3 ones, and it doesn't go into the dentin like my that last one. So I'm just labeling those first 3 fiber groups. Okay, so they get their, and on this side, just labeling the first 3 fiber groups. They don't go that deep in the bone. They stop right where they do in black, right there. Okay, so they're named the alveolar crest fibers. So just notice they're go from the cementum to the alveolar crest. They get their name because they're at the highest point of the alveolar bone. Okay, and as we continue apically, the orientation is going to change. And what I want you to do here is draw in 3 fiber. There's actually a couple already drawn for you, but just I'm going to draw in a few more that are more horizontal in their location, like this. So this one that's there, just going to draw them a little bit. Okay, that group is called the horizontal fibers. And Elio, what does it say about those fibers? About their attachment?
You want me to just read it?
Yeah.
It says cementum of cervical third of root to adjacent alveolar bone proper.
Okay. And they get their name, I'm just going to draw them up here, because they have a horizontal orientation. See, that's what they look like as they go from the cementum to the, and they're, just think if we take this whole root, they're more in just the cervical third of the root. Okay, the next group is the largest group. And these are the oblique fibers. And notice instead of having a horizontal orientation, they are at an angle or oblique. So I'm just kind of showing how they, on the tooth root. Okay, so they start about up here, and I'm not going to color everyone in, but they end about there. So they start, they're just apical to the horizontal fibers, and then they're going to end right about there. So they're all, so they are the largest group, and there it says on the outline that they're in the apical 2/3 of the root. So they're the biggest, overall, the most important group. And then finally, if you notice, just rating apical refers to the apex, or the tip of the root. So all of these that just radiate around the tooth apex are called the apical fibers. Okay, so it says they radiate from the cementum of the root apex to the fundic alveolar bone. Fundic just means the alveolar bone that's near the root apex. So I'm just going to draw. So this would be like your fundic alveolar bone. It's really just apical alveolar bone. That's what it is. Okay, and on an actual slide, these are relatively easy to make out. If we go to the mesial distal view, again, here's my alveolar crest. Here's my alveolar crest fibers. And then I'm going to adjust the bracket a little for the horizontal. Right in here. That's all in the cervical 1/3 on both sides. And then forming the largest group are the oblique again. So starting up here, I'm just going to angle these a little more. There's really like an oblique orientation. Okay, so they go all the way down to this right there. So that's the largest group. And again, we'd have our apical fibers around the root apex. So from all views, I can see all of these fiber groups. Okay. Finally, in a multi-rooted tooth, there are what are called interradicular. Radicular is the adjective for root, and the prefix inter means between. So, Tyler, will you go ahead and read what it says about the interradicular?
Cementum of root infurcation areas to alveolar bone proper of interradicular septum.
Okay, so everybody, you guys can see there's your bifurcation in the mandibular molar, and in the maxillary molar, there would be a trifurcation. So it's only these fibers that are right in that, that have this fan-like arrangement right in there. Because what I want to show you with a multi-rooted tooth, again, because two roots here, you have two sets of apical fibers for each root. And then what I want to show with this is that also in the interradicular area, you have more like oblique fibers. And I'm going to make the oblique ones go up a little higher there than shown. Just so do you see how you have like a double, for each root, you have oblique fibers on each side of each root. And the interradicular ones are just in this, you know, bifurcation area right in here. I'm going to go back and label the horizontal ones too. And this picture on the mesial and distal isn't exactly symmetrical. Okay, so as I go out from the crest, alveolar crest to horizontal to oblique, but then if you notice on the mesial aspect of the distal root, I also have oblique fibers. And then when I'm on the mesial root, the distal aspect, I also have oblique fibers there. But then right in the bifurcation, more in this fan-like arrangement, those are called the interradicular fibers. Okay, so collectively, what do these principal fibers do? They attach the the tooth root, the cementum, to the alveolar bone. And they're type 1 collagen fibers. They're non-stretchable, so they're going to keep the tooth stable in its bony socket. That's overall their main function collectively. They're going to provide mechanical support. But let's look at these groups individually and see what kind of forces that they resist on page 3 of the outline. We're going to look at these fibers in lab tomorrow. Okay, so during speech and mastication, as well as what we call, I'm going to just write it down here, parafunctional habits. Parafunctional habits are good examples of that are when patients grind or clench their teeth. They're not the intended function of the teeth in occlusion, but people have these habits called parafunctional habits. So there are forces acting on the periodontium during speech and mastication, as well as during parafunctional habits. And the fibers are going to be resistant to these mechanical forces on the tooth. And the specific kind of force they resist depends upon their orientation. So there are intrusive forces shown in the middle picture. Notice that's like when you're biting down on your teeth, straight down. That's an intrusive force. An extrusive force would be like if you were trying to pull your tooth out, or just think if you're eating some kind of sticky candy like caramels, you know, your teeth are going to stay in the socket. They're not going to, if the attachment apparatus is intact, the pulling forces from trying to unstick that candy is not going to pull your tooth out. And then when we are chewing, you may think that we mainly have these intrusive forces, but there are actually when we're chewing, there are actually horizontal forces. It could be in the direction of the arrow, or it could be in the opposite direction. And these are what we call lateral, horizontal, or tilting forces. It just forces acting in a horizontal plane. And then not shown, I'm going to draw another arrow just on this one, and those are rotational or twisting kind of forces. We even have a little bit of them. And these, during parafunctional habits, these lateral and rotational forces may be excessive on the periodontium and actually lead to some damage. Okay, so when we look at these individuals, you can see when you're just biting down, when you're in occlusion, and just bite really hard, bite a little excessively, your tooth stays suspended in its bony socket. So what is the main fiber group shown right here that's limiting that? Tiffany, what's the main fiber group shown here?
Is it the oblique?
Okay, good. So it's the oblique fibers that are the main fiber group. They're the largest group, and they just keep your tooth from being forced down into the bony socket, into the alveolar bone. They prevent that. They keep it suspended. And they act as shock absorbers. Okay, now this just shows a horizontal or lateral or tilting force in one direction, but if you notice, if we look here, force is going in that direction. So on the side away, on the side of that force, we're going to see the horizontal fibers are going to keep the tooth from tipping. But it's also the apical fibers on the opposite side, on the side toward which the force is directed, that are going to keep the tooth from tipping or tilting. And then what are these fibers that adjacent tooth isn't shown, but what are these fibers that also resist the lateral or tilting forces right up here? What are these fibers? Hannah? That we labeled up in the gingiva, that if there was another tooth here, it would keep them from tilting.
Let me look. I'm sorry. I'm going off of my laptop and my paper
Yeah.
notes. Is that the alveolar ones?
No, they're actually shown. I'm going to come back to them. They're actually shown right here at the crest, but I was just getting at that they're the transeptal ones. Remember, they act like the little boards between the fence posts. So so horizontal fibers of the PDL, apical fibers, and transeptal fibers actually work to keep the tooth from tilting in its socket. So if the force were going the other way, it would be the horizontal fibers right here, and then the apical fibers on the side to which the force is directed, and then the transeptal fibers on this side. Okay, but also think of if you were trying to pull your tooth out, or if you had your teeth stuck together with candy and they came apart, the apical fibers are keeping your tooth in. So the apical fibers are the main group that resist the extrusive forces by preventing the tooth from being pulled out of its socket. It's the apical fibers.
Which one was the one before that? The one that says prevent.
Well, the horizontal, the apical, and then I just mentioned also shown are those transeptal fibers that connect the cementum of one tooth to the adjacent tooth.
So it's horizontal, apical, and transeptal fibers.
Transeptal, right. But remember, the transeptal fibers aren't necessarily classified as PDL fibers. They don't hold the tooth in its bony socket. They just keep adjacent teeth. They connect one tooth to another tooth and prevent them from tilting.
Okay.
Okay, so the final thing I want to mention are these alveolar crest fibers. And if you in our diagram, we labeled them as primarily being in this direction. They go from the cementum and an apical. They're a very small group, but not shown on your diagram. Sometimes they might be oriented in this direction, and sometimes they might be directed more horizontally. So they're a very, very small group. So we can just call them like accessory. They assist the other fibers. But because they're so small, just at the crest, they're not going to play a major role, but they do. And I just want to point out that when there's early bone loss, let's just say if there's loss of bone right here, if there's loss of bone right here, that crestal bone, that alveolar crestal bone is lost, and the attachment of those fibers is lost, your tooth is not going to be loose. Or the patient's tooth is not going to be loose. It's a very small group of fibers. There's not going to be substantial loss of attachment at this point. So that's when a patient has like less than 15% bone loss, what we call radiographic bone loss, when that fiber group would be, their attachment would be destroyed. Now, if we were getting down in the horizontal and down in the oblique fibers, we would start to see tooth mobility. And there have been some patients in the clinical situations where their tooth is just kind of hanging on by the apical fibers and the tooth is very mobile. There are times when a clinician has to actually hold the tooth to scale on it. Okay, let's wrap up with these interradicular fibers. And I just want to show that they've kind of functioned like the apical fibers, but so originally I had drawn them in the same color just to show that they, like the apical, these are the apical fibers, and then the interradicular, if there was a extrusive force, this would kind of help stabilize the tooth in the bony socket right in that area. And also they'll resist like the apical fibers resist tilting or horizontal forces in either direction. Okay, so to summarize, principal fiber groups, type 1 collagen fibers attaching the root to the alveolar bone. They don't stretch. They keep it stable. When the attachment apparatus is compromised and diseased, this attachment is lost and teeth can become mobile. Okay, let's go to the top of page 5. Can somebody just tell me what time it is? I didn't bring my phone in and I just don't have the time. Can someone?
10:09.
What is it?
10:09.
10:09.
10:09.
Okay, thank you. Okay, so on the top of page 5 of the outline, we're going to reiterate the other components of the PDL. We already know the fibrous matrix is the main component, specifically those principal fibers, which are type 1 collagen fibers. So we're going to be using these drawings to label the specific components. Okay, so it's mainly type 1 collagen. So where these principal fibers are, where I pointed out earlier, the arrangement of the PDL, these are all the type 1 collagen fibers, and they're actually represented with this blue diagrammatic representation. Those are the, okay. And we've already seen how they resist tension in the planes in which they are oriented. So when a force acts, they're not going to stretch. They're going to keep the tooth nice and stable in the periodontium. One thing that I want you to understand, though, is that in addition, these interstitial areas that are loose connective tissue proper will have a little bit of type 1 and type 3 collagen in there, but it's more delicate. So I'm just drawing in a little bit of type 1 and type 3 collagen in the interstitial areas. Okay, now the other thing, it says these principal fibers, they form a plexus or network. In this picture, it just looks like they go straight across from the cementum to the alveolar bone. So it looks like they just go right across there, but they actually kind of, so here's one that might be in this group at first and it splices off to go with another group. So there's like this plexus or this kind of intercommingling of fibers. See how this fiber is kind of down in this group and then it may go up in with another group. The second thing that I want you to get out of this is that they have a wavy pattern. So these type 1 collagen fibers, I'm just going to draw some in here. They're not really like this. They're not like, well, that wasn't perfect anyway, how I drew it. But do you see how there's a little bit of waviness to them? So what is the significance of this? It just means they're not out to their complete length, so that when a force acts on this, they will like pull straight to their length, but they won't stretch beyond their length like an elastic fiber. So when you bite down or when you try to push your tooth or whatever kind of force is acting, there is a little bit of give because they're not completely stretched out to their length. And when a force acts on them, they'll just stretch out to their length. So just picture I have a rope that I'm holding and and when I pull it taut, that's when it's extended out to their length. But it's not going to stretch. If I keep pulling, it's not going to stretch beyond it. So I'll have this, and then when I pull it straight, it'll only go out to its complete length. It won't stretch beyond this. So it's because of this, we can say that a tooth in its bony socket has like a little bit of quote unquote mobility because these fibers aren't taut out to their whole length when forces aren't acting on them initially. Okay, so this is actually showing you an electron micrograph of those collagen fibers and showing that they actually are wavy. And there's another electron micrograph showing the principal fibers with this waviness. Okay. The next point about these principal fibers is when we look at these principal fibers, the little ends attach in the bone and they attach to the cementum. Not in the dentin, just the cementum there. Okay, so these end pieces, or what are called the terminal portions of the principal fibers, are embedded in cementum on one side. They're locked into that mineralized tissue or cemented into it. And on the bone side, they're locked in. And these end pieces are collectively called Sharpey's fibers. So I just showed it just right here, this little end piece in the bone right here and the little end piece in the cementum. It doesn't go in the dentin. Mine went in the dentin a little bit. Those little end pieces of every principal fiber are called Sharpey's fiber. And if we look at our diagram here, let's just highlight them. The little end pieces in the bone, these are Sharpey's fibers. Or they're right here. And this illustrator already labeled some right down here where it's encircled. But see, on both the tooth and the bone side, those are called Sharpey's fibers. When there's periodontitis, loss of attachment, these fibers aren't attached in the bone or the cementum. That attachment is lost. This is a common National Board question. What are the terminal portions of the principal fibers of the PDL called? They're named after a Dr. Sharpie who first studied them. They're not sharp or make marks like a Sharpie's marker, but they're named after this doctor. So when we actually look at it on this microscopic picture, you can see, especially on the bone side, these little striations or little lines in the bone. Those are Sharpie's fibers. And then here they're in the cementum. Those are Sharpie's fibers. So they're just like the end pieces of a rope locked into a calcified material. Here's a special slide that shows the collagen in blue, and it shows us the cementum of the tooth, and we can see all these Sharpie's fibers or end pieces locked into the cementum. In this picture, this used a different stain. It's showing you on the bone side here, the black represents the Sharpie's fibers locked into the bone, and up here where it's darker, that shows you the cementum where they're locked into the cementum. So when there's normal function, normal occlusal forces acting on a periodontium, we're going to see the normal arrangement of the principal fibers as we looked at here. This is a functioning PDL, normal width here. In this case, we're looking at the oblique fibers because they have that oblique angle to them. But when a periodontium, let's say, is in hypofunction, and I didn't mention this earlier, but this would be like when, let's just say you had an extraction of number 30, patient had an extraction of number 30, number 3 is no longer occluding with that tooth, so there may be less occlusal forces. And if we look at this PDL right here, notice we don't see these groupings of principal fibers alternating with the interstitial areas. It just looks like the fibers are going in all different directions per se. Okay. Besides type 1 collagen, which is the main component, it makes up those principal fibers. I mentioned earlier that there could be there is some type 3 collagen in the loose connective tissue of the interstitial areas. So earlier I had drawn in there some type 3 collagen. It could also be more delicate type 1 collagen. And remember, those types of loose connective tissue, they're more delicate, and they're more random in their orientation. And we're always going to see them encasing blood vessel areas. Okay, just like the gingival connective tissue, there are also oxytalin fibers in the PDL. You can't see them because of the stains that are required, but I'm just going to draw them in black to represent them. And recall, in connective tissues, they provide mechanical support in 2 ways. They anchor or secure blood vessels. So they kind of limit the movement of the blood vessel, kind of keep it in place, although it can move just a little bit, just like a boat can. When it's anchored, it'll move around slightly, but just in a limited area. And then they also support the principal fibers. So if we drew them in, all the pinks, the type 1 collagen, but we might have oxytalin fibers in here reinforcing the type 1 collagen fibers. And one thing that's been interesting, it's written on your sheet there, that researchers have found that when orthodontic tooth movements when a person's in ortho treatment, there are more forces placed on the periodontium, and they actually see an increase of these oxytalin fibers to provide mechanical support in response to those extra forces acting on the periodontium during orthodontic tooth movement, which we're going to talk about more on when we get to the bone unit in the next couple weeks. Okay, so the main component, type 1 collagen, making up those principal fiber bundles, the alveolar crest, horizontal, oblique, apical, interradicular fibers. But we also have some type 1 collagen and type 3 collagen in the interstitial areas. And then in the interstitial areas, we have some of these oxytalin fibers. Okay. Unlike connective tissue proper, there are no elastic fibers, not even in the loose interstitial areas, not even in this area. There are no elastic fibers. So that's one way that the PDL is different from connective tissue proper. Okay, no elastic fibers for stretching. Also interesting, I don't have it written here, there's no fat accumulation in the loose connective tissue here. You can't get a fat PDL. Okay, ground substance. This is a good review for the quiz. There's nothing different about ground substance in the PDL compared to just connective tissue proper, including the lamina propria of the gingiva, except there's not a lot of it other than in the interstitial areas. So it has the same physical properties, amorphous, gelatinous, made up of these protein carbohydrate complexes, for example, those proteoglycans, provides mechanical support by holding the connective tissue together, providing and resisting compression, biologic support, medium for the diffusion of nutrients. So where we're mainly going to see the ground substance is in the interstitial areas. All those white spaces represent the ground substance. So there's nothing different about ground substance in the PDL. It's just there's not a lot of it. It's mainly found in the interstitial areas between the principal fiber bundles. Okay. Let's talk about the cells of the periodontal ligament. There are a large number of different cells in the periodontal ligament. And on the left side of your outline, it lists the general connective tissue cells, the cells that we already studied under connective tissue proper: fibroblasts, mast cells, macrophages, and even some of those wandering cells or defense cells. And then we're also going to see these cells called mesenchymal stem cells. I'll explain that momentarily, but that they're not found in all connective tissues. Okay, they're found in certain areas, and the PDL is one of them. Also, your pulp tissue, which we'll be studying later. And then we're going to see that not only do we have these general connective tissue cells, we're also going to see that there are specialized connective tissue cells. We're going to see that there are cementoblasts and osteoblasts, as well as occasionally, I put that in parentheses, I'll explain that momentarily, that sometimes we see cementoclasts, and even in health, we're going to see osteoclasts. And then I just want to make sure everybody realizes that this is a separate category, doesn't go with, it's not they're not connective tissue cells, they're not specialized connective tissue cells, but there's actually some epithelial cells that are found in the PDL. And again, I'll explain how they get there. But if you look at this picture, I drew a line where the PDL is. You can see that there are a lot of different cells in the periodontal ligament. So let's focus on these different cells. And I just to mention, there is the epithelial cells that I'm going to talk about are specifically called the epithelial rests of Malacea, which is listed on the outline. Okay. So fibroblasts are the main cell. They're going to make all of the extracellular matrix. All the fibers in the PDL, all the ground substance is produced by the fibroblasts. Nothing different from connective tissue proper. Okay, they're going to destroy, they're going to turn over the worn out fibers and ground substance and replace them with new ones. Nothing different. They make those enzymes called matrix metalloproteinases, or MMPs, for the normal turnover. When disease hits the gingiva, when it hits the PDL, we see an increase in their production with a net destruction of connective tissue. Okay, we're going to see net destruction. Okay. So all this information about fibroblasts is applicable in the PDL. So when we look at this little inset here, or even the one that you have in your packet, most of those cells, especially the ones we see in covering the principal fibers, the main cell is the fibroblasts. So those represent mainly fibroblasts. When you look at a blow up of this, again, there can just see among those principal fibers, tons of fibroblasts. Okay, mast cells. Just going to draw one in. Remember, they're normally in connective tissue. They live near or in the vicinity of blood vessels. In health, they have an unclear role in the maintenance of health. And this was a question that some of you got wrong on the homework, so I just wanted you to make sure that these are different from the wandering or defense cells that come to the aid of the connective tissue. They don't come from the bloodstream and go to the connective tissue. They're normal residents. They just live near blood vessels. And their role in the maintenance of health is not completely understood, but in health, they're not going to release their granules that are found in the cytoplasm. And then we already talked about when they're injured, when the tissue becomes inflamed, these cells release their granules that affect cause inflammation. Specifically, they affect the blood vessel properties that we see in inflammation. Okay, so the same thing that applies to the lamina propria of the oral mucosa, specifically the gingiva, applies here as well. Okay, macrophages. Okay, remember they're normal residents, even in health, and they're there in low numbers. So I'm just going to draw in a macrophage. They're larger cells. And remember, they act as the phagocytes, which they have the ability to engulf tissue debris. So they're going to clean up worn out fibers that have been destroyed and ground substance, and they're going to clear out any pathogens or microorganisms. When the tissue is injured, we'll see more of them. And one thing I didn't mention before, that in the periodontium, when more of them come to the area when there's inflammation, either in the gingiva or deeper in the periodontium, as in this area, they too produce enzymes that destroy the connective tissue. And then finally, the wandering or defense cells, again, are in low numbers, but I'm drawing an X within the blood vessel, and these are blood cells, such as neutrophils and lymphocyte, that leave the bloodstream and come to the defense of the tissue. So I'm just drawing one of those cells that leaves the bloodstream. So they're different from the mast cells. They're the white blood cells. Okay, so far, these are all connective tissue cells that you're familiar with. Let's look at the specialized cells next. There are osteoblasts in the PDL that produce alveolar bone on the bone side. And then in the PDL, there are also cells that produce cementum, the cementoblasts. So on our drawing, let's just show that. Let's just draw, I'm going to represent nuclei. If on top of the bony surface, I'm drawing some cells at the surface. This is the bone side. This is the alveolar bone that's shown. And here's the cementum side. And on the surface of the cementum, I'm just drawing some nuclei, are the cementoblasts. So what I'm showing you is that the cells that produce the alveolar bone are outside of the bone in the periodontal ligament space. Osteoblasts on the bone side, cementoblasts on the cementum side. So they actually line up all along those tissues. I'm just showing you in one little area, right? In this area. So because of this, we can say that alveolar bone and cementum are products of the periodontal ligament, because the cells that produce those tissues are actually found in the periodontal ligament. Okay, and this just shows you a representation. If you follow, this is on the cementum side. If you just follow all those nuclei, if I just follow all along the PDL at the surface of the cementum in the PDL, those are all cementoblasts. And if I go over here where it says B, that's the bone side, I can see all of those osteoblasts lined up along there. Okay, osteoclasts are normally found in a healthy periodontium to some degree. And we're going to learn about, start talking about bone next week, but osteoclasts are normally there. And just remember that class, if you remember that saying, blast build and class kill, you'll remember the functions of the cells. So osteoblasts produce or build bone, whereas osteoclasts kill, or we can say destroy or breaks down bone. And in contrast to cementoblasts produce cementum, whereas cementoclasts destroy cementum. But I have an asterisk there, and I want you to qualify that they only destroy cementum under certain circumstances. In a healthy periodontium, you are not going to see cementoclasts, whereas you may see some osteoclasts. When would be a healthy situation? What would be a healthy situation where cementum would be destroyed? When would this be? Cementoclasts are usually there when there's some kind of pathological condition taking place or situation. But there is one healthy situation where we are going to see cementoclasts there. Can anybody think of a normal process that's not considered disease where cementum would be destroyed? Well, it would be when the primary tooth is exfoliating or shedding. When primary teeth are exfoliating, the primary root is destroyed. And the loss of attachment to the bone occurs. That's how an exfoliating tooth becomes loose. And it may be it usually is a gradual process. But in that situation, we do have cementoclasts. That's a healthy, normal physiologic process, exfoliation of primary teeth. Okay, so I am going to have you just kind of in this area draw in an osteoclast is a very big multinucleated giant cell. I'm just drawing 3 nuclei in it, and that would be found at the surface of the bone notice I drew it in the PDL space. Or I could draw one right here where there's like a little scalloped area in the bone. Okay, so even in health, I would see osteoclastic activity. I'm not going to draw a cementoclast because they're at the surface of the cementum because they're normally not there. And I just want to point out that cementum is more resistant to resorption. What is resorption? Resorption is simply a destruction of a mineralized tissue. It takes certain triggers to activate the cementoclasts and cause them to destroy the cementum. Okay, so there is going to be some osteoclasts even in a healthy situation. Okay, so I wanted to just show you the osteoclasts are really easy to make out in the periodontal ligament. You can see these where the black arrows is pointing. There's a ditch-like area where they've taken a bite out of the bone, just like a bite in a sandwich. And you can see they're very large but they're still in the periodontal ligament space. They're not in the bone itself. And here's a close-up of one of those very large cells in a little ditch-like area, but this is still the periodontal ligament space. And then here I'm just showing you that where this is the cementum, here's the periodontal ligament, and there actually has been some root resorption, ditch-like areas in the root. And this is a tooth surface showing similar to the bone where these cementoclasts are destroying the cementum. Here's a PDL space again. And there's a close-up of one. This one has actually gone way into the dentin. Here's the PDL, cementum covering the root, and in this case, there's the cementoclast destroying the root. Okay, so the PDL has cells that are common to connective tissue proper. And it also has the specialized connective tissue cells that I just discussed with you. One other type of cell is what's called the mesenchymal stem cell. Stem cells are cells that have not turned into specific cells, or they haven't differentiated into specific cells. Mesenchymal, that word means embryonic connective tissue. So they're found in areas that still have this embryonic connective tissue. Just think of them as being like on reserve cells. So let's say we have our normal cells, fibroblasts or osteoblasts, and they become injured. These cells can be on reserve or triggered to replace them. So these are non-specialized cells. They're what we call undifferentiated cells. They haven't become a specific type of cell yet. They're in the connective tissue line. That's what mesenchymal means, embryonic connective tissue. And what happens is if they're given the right stimulus, they can specialize and replace other cells that I've already mentioned. So let's just say on the root surface, a cementoblast gets injured, a mesenchymal cell can be triggered to turn into one and replace it. So I just wanted to show you what is being done in a laboratory situation. They're taking like a little scaffold material and placing these stem cells on it and trying to trigger regeneration of the attachment apparatus. See, it shows you where all this, there was bone loss here, loss of PDL attachment, and they're trying to take these stem cells to see if this can be regenerated. And it's something that they're, working at. Someday people that have had all this attachment loss may be able to have it restored through manipulation of these stem cells that can be triggered to produce those tissues of the attachment apparatus again.
Could you go back to the other slide really quick?
This one?
Yeah.
Yeah, sorry, it's just acting funny here.
It's okay.
Okay,
Thank you.
Yeah, sure. Could I just have a time check, please?
10:46.
Oh, 10, okay. All right, let's, okay, we'll do that in lab then. Let me just these epithelial rests of Malassez. I'm going to draw them in just anywhere on your picture, and I'm going to just draw them like a cluster of grapes, or you might see them like a cord of epithelial cells. Okay, how can epithelial cells be found in a connective tissue? These are groups of cells left over from root development. They're called rests because they are inactive cells. They usually don't keep replicating and form extensive areas of epithelial tissue. They're called the rests of Malassez, named after a French doctor who first studied them. So they're just inactive, or what we call latent or resting groups of epithelial cells. And for right now, all you have to know is they're left over from root development. There's a epithelial structure that is important in the formation of the roots of our teeth. And this is just left over. And in most of us, it is of no clinical significance. But in some individuals, these cells can be stimulated to proliferate, and they can turn into cysts, different cysts or tumors. But this isn't, in most of us, if we were to do a section of a tooth in situ, we would have some of these without any clinical significance. But just the clinical significance is they can be triggered. Some kind of stimulus like inflammation can trigger them to become cysts, and even sometimes different tumors. Okay, what I'm going to do, it will be later in the week. I'm going to record the information about the blood vessels and the innervation of the PDL, and also the gingiva at the same time. That's on our previous pages. I'm just going to integrate that material together because their blood supplies actually overlap. Okay, on the very last page of the PDL handout, it summarizes, I just want to finish up with this. It summarizes the functions of the PDL, and where it says mechanical or physical support, what is the mechanical support a function of? What provides mechanical support in connective tissues? Sydney, what? Anybody?
Is it alveolar bone and cementum?
Okay, could you just say that a little louder, please?
Is it alveolar bone and cementum?
Okay, they do provide mechanical support, but in the periodontal ligament, what specific, and the fibers. So on that last page, the mechanical or physical support is a function of fibers and ground substance. And which is it mainly? It's mainly a function of the principal fibers, the type 1 collagen fibers. Without their attachment, and what's the name of their attachment to the bone? Those little end pieces that get attached in the cementum and the bone, those are the Sharpie's fibers. Okay, on page 8, there's a formative function. If we go down to B and C where it says formative and resorptive function, the PDL has these functions because of the cells it contains. Okay, it has and it has a resorptive or a destructive function because of the cells that it contains. So already listed there are fibroblasts, cementoblasts, and osteoblasts, and listed under resorptive are, and that one's qualified, are fibroblasts, osteoclasts, and cementoclasts. So the formative or resorptive functions relate to specific PDL cells. Now I know I haven't talked about the blood supply of the PDL, but I just want to, I'm going to do this on the specific recording, but I just want you to understand that the PDL provides biologic support because of those interstitial areas. Remember, there's blood vessels in the interstitial areas that are going to provide nutrition to the surrounding tissues. And it lists all those tissues there, the PDL, the cementum, alveolar bone proper, and the gingiva. And then the sensory function that I'll cover on the recording too is a function of the sensory nerves found in the interstitial areas. And I'll talk more about the types of sensations, but they're listed there, and I'm going to describe that in the recording. Okay, I just want to stop here. Show one more thing on the picture we were labeling earlier. Okay, where the blood vessels are in the interstitial areas, so let's just say right here, here's this blood vessel. Nutrients are going to be supplied to the PDL, but because that PDL is between the cementum and the alveolar bone, it's also going to supply the cementum, which is avascular. It's going to supply part of the alveolar bone, and not shown higher up, there's going to be overlap of blood supply with the gingiva. So I just wanted to show on the diagram how the blood vessels in the interstitial areas of the PDLs provides biologic support, provides nutrition to the PDL itself and the surrounding tissues. Okay, let's stop there. I did want to go over one of the homework questions. It's on page 6, where the different components and their functions. I just wanted to make it clear that when the type 1 collagen of the lamina propria is attached to the bone, which it is with the gingiva and it is with the hard palate, it makes that tissue stable and immovable. Now, the gingiva is also attached to the tooth, as we talked about with all the dentogingival fibers last week and today for a little bit. With lining mucosa, the mucosa is attached to muscle, but it's still, when it's attached to muscle, it's with the type 1 collagen fibers, and that makes the mucosa, it makes the lining mucosa move and function with the muscle. But what causes the lining mucosa to stretch and be flexible are the elastic fibers. So some of you were getting those two confused. And then compressibility relates to having like a cushion, a loose connective tissue, the submucosa in the area. When a tissue has a submucosa, there's a little bit of compressibility. Does anybody else have any other questions?
So our test is tomorrow, right?
Yeah, the quiz is tomorrow on the